Well, it's 1:02. I think we might start. So welcome to this TARC webinar. We've been asked to talk as the Northern Australian Regional Digital Health Collaborative Team. It's quite a mouthful, NARDHC for short, about digital health innovation and application to rural and remote health services in Northern Queensland. And I would like to start by acknowledging country and the traditional owners. I'm coming to you from Wulgurukaba and Bindal country here in Garrambilbara or Townsville, and I'd like to pay my respects to traditional owners of all the lands that we're all on right across the region. Pay my respects to their elders past and present, and to all Aboriginal and Torres Strait Islander people. So we have a really interesting session today. I'm Sarah Larkins. I'm a GP and Professor of Health System Strengthening here at James Cook University in the College of Medicine and Dentistry. I've got two wonderful colleagues presenting with me who are part of the NARDHC team. Dr. Michelle Krahe. Michelle, would you like to introduce yourself quickly?
Hey everyone, I'm Michelle Krahe. I'm a Senior Research Fellow and the Program Manager of NARDHC. Great to be here.
Fantastic, thank you. And Daniel Foulkes. Daniel, would you like to introduce yourself?
Sure. Yes, I'm Senior Research Fellow for Data Interoperability. My background is technical, but I've worked for 20 plus years in the health space and enjoy a lot of collaboration with clinicians in the process.
Fantastic. Thank you, Daniel. So we've got a really interesting session today. Just by way of housekeeping, the session is being recorded and the recording will be available afterwards. We're very happy to share the slide deck afterwards if people are interested in that. Just let the TARC team know and we can share that. We've been asked to talk, as I said, about digital health innovation and the work of NARDHC. And we've divided the presentation essentially into three sections. So I'm starting off briefly to talk about why we're doing this. Digital health in Northern Australia, in North Queensland, is very much a means to an end. We have a stretched healthcare system, we have workforce shortages, and we're interested in how best we can use digital technology to improve access and healthcare and productivity of stretched teams in the bush. Then we've got Michelle talking about NARDHC as a collaboration and some of the work we're doing and the collaborations we're building around applying and implementing digital health technologies and the broader framework around implementation and evaluation plan for digital health across the region. And then Daniel will talk about interoperability, because one of the big barriers we hear from clinicians all the time is that systems don't talk to each other. We have data sitting in all sorts of different data systems and repositories, not available to people at the point of care, and thinking about how we might make a plan to make that work better over the longer term using health information exchanges. And Daniel will explain a little bit more about what that is, and specifically some work we're starting on in doing this in rheumatic heart disease and acute rheumatic fever and the registers and information sharing in that area. So I'll talk for about 5 or 10 minutes at most, and then Michelle and Daniel will each have a 15-minute or so presentation, and then we'll have some time for questions and discussions. And look forward to that. Thanks, Michelle. So this is not just looking at some of the names around the place. This is not news to many of you. The health system overall in Australia is doing really well. It's the envy of many countries, but it can certainly improve. So we're doing very well. Some of the issues that we have are related to access and equity issues, and some real issues in terms of the health workforce, particularly in the north and rural and regional areas. The challenges that remain are that expenditure is growing, so the costs of providing healthcare services are going up. Demand is growing, wait times are increasing. This is going to get worse and worse in the face of an ageing population, increasing multi-morbidity, and ongoing workforce shortages. And the access is really unequal. So we have too many services provided to people that need them less, generally the well-off people in metropolitan centres, and not enough services provided to the people with the highest health needs in rural and remote areas, who are also more likely to be socioeconomically disadvantaged, have high healthcare needs, and large Aboriginal and Torres Strait Islander populations as well. Thanks, Michelle. So I commend you all to read the recent Productivity Commission report, Leveraging Digital Technology in Healthcare. It was released in May this year. It's very easily available on the web. But this highlighted some of the savings and benefits that could be gained for the health system, thinking broadly and thinking largely in economic terms, right across the health system. So the benefits for consumers, telehealth alone saves the consumer around 895 million if used effectively. So the team has just been granted actually a NHMRC grant over the next 5 years, looking at the safety and quality of telehealth based on our experience in North Queensland. So that's an important project. Also looking at how the cultural acceptability and cultural safety of telehealth as a means of care can be optimised for the populations we serve. In terms of patient level care, there are a lot of cost savings, direct cost savings through streamlining electronic medical record systems, and the productivity savings through workforce efficiencies that have been estimated from doing that better have been reported at up to 5.4 billion each year nationally. So, these sort of figures start to gather attention from policymakers, governments, and increase the interest in that. So although that's not our primary driver, efficiencies and productivity gains in an atmosphere of workforce scarcity are important. And system-wide, when we've got overstretched health workers, implementing digital technology and AI optimally into the health system could save 11 hours a week for every health worker through efficiency gains. So these are some real potential benefits reported by the Productivity Commission. Thanks, Michelle. So we have established NARDHC, Northern Australian Regional Digital Health Consortium. Michelle's going to talk a little bit more about the partners in that, but all of this work aligns with the activities of NARDHC. So we're focused on rural remote health services. We're focused on bringing together rural and remote health service providers and managers with digital tech experts to understand best how digital innovation and infrastructure can be deployed within our health system, how we might work towards health information exchanges and optimised interoperability in North Queensland, and how we can grow the capacity and capability within the workforce and within consumers of health services in terms of engaging with digital tech and digital technology. It's in a broader health ecosystem where there's a lot of talk about this. There's a national digital health strategy, also a national interoperability framework for Australia. We're interested in equity and access, and we need to design everything in a very collaborative way. So the other piece of work that we're doing in this space is our teams evaluating the National Australian Teletrials Initiative, and we're part of a team with Queensland University of Technology evaluating the Teletrials program, which is another application, I guess, of digital technology aimed at improving access to clinical trials of people in rural and regional Australia. So a lot going on in this space. Michelle will talk a little bit more about what NARDHC's doing, and over to you, Michelle. Thanks.
Sarah. Thanks, everyone. So I have the pleasure of introducing NARDHC, which is the Northern Australian Regional Digital Health Collaborative. We are exactly what we say on the tin. We're a digital health collaborative with a focus, strong focus in Northern Australia. We were established in October of 2021 and funded by a federal government fund called the Strategic University Reform Fund, which was at that stage the Department of Employment, Skills and Education. And that fund was really established to support tertiary education, to build links with business and industry, and also with local employers. It was about the translational commercialisation of research, and also in response to local needs and local priorities. So you can find out a little bit more about us on our website, www.nardhc.org. We have a fresh new look. And really, I just want to acknowledge our sort of founding partners. We're led by James Cook University in collaboration with Optus, the CRC-NA, Northern Queensland Primary Health Network, and the Australian E-Research Centre at CSIRO, and of course TARC. So everyone here today is obviously part of the collective of TARC, and a part of our partnership. So please feel welcome to engage and connect with us. So the distinct approach for NARDHC is really that we are one of the only digital health collaboratives that are regional, rural and remote focused, and that we are a collaborative of really strong partners and networks beyond just the 6 that I mentioned earlier, that are actually based and working and embedded within the community that we're serving. We also have a really strong solutions or application focus, a very strong community focus, and the application of digital tech from enabling end-to-end care. And certainly, where we sit here today, the 3 of us, and our extended team, we sit within an institution that's an anchor of community. Also, we're really focused on the translation of our skills, and we have some really fabulous research and technology expertise that is placed in Northern Australia. And so if you're interested in finding a bit more about us, have a look at our website. We have our strategic plan, our current strategic plan, and we are working towards a new one that will align with the new digital health national plan as well in the coming months. So NARDHC is really about improving health and healthcare delivery for Northern Australia through digital health solutions. We have sort of 5 key areas of activity that we work in. We are quite a small team, so we're quite stretched, but we're doing our best to work in a really collaborative way with our partners and anyone else who is working in this space. So we're really interested in creating a focus of digital innovation and investment, and hence the reason of the collaborative being established. We try to be a link with industry stakeholders and local communities across Northern Australia. We are ramping up our rollout of things like roundtables. We have really great governance and network boards that are involved in helping to direct NARDHC. And we also have a really fabulous skills-based training for students in the health workforce. And in fact, so that little snippet there, if you go onto our website, you can get access to it. It's actually one of the only micro-credentials in the country that is focused on digital health for rural and remote health workforce, and it's absolutely free. So take a look and share it amongst your networks. We also are really interested in the implementation and evaluation of digital health innovations, and that's primarily where myself and Daniel sort of fit within the network, and we'll each talk about our respective roles a little bit more. And lastly, but not leastly, we have invested in research industry collaborations about, to encourage the adoption of technologies and the development of digital health that is, applicable and suitable for Northern Australian communities. And that's been primarily through our seed-funded support. So we've had 2 rounds of seed-funded project grants, and we've had about 9 projects all up, including some of our commercial Impact 10X programs. And it's almost been about $250,000 invested into these projects. And they really do cover quite a broad range of, digital health domains in the health sense. So anything from remote patient monitoring, telehealth, and the integration of artificial intelligence. So what I'm going to finish up my session today is talking to you a little bit about a couple of these key seed projects, just to give you a bit of a taste of the types of projects that we support or have been supporting. So this first one here was a grant, a project that was improving access to virtual and integrated care. For any of you who are Townsville based, you may have seen a bit of media about this in the recent months. It's a project that's led by Janine Cox from the Northern Queensland Primary Health Network, and it's really around the adoption or integration of digital patient management solutions for residents living in residential aged care facilities. And as part of this seed-funded projects, it was the rollout of Vision Flex telehealth carts in three facilities. And just last week when I spoke to the team, they were actually scaling up and I think Kieran, shout out to Kieran if he's online, I think he was going to be here, who's managing the program. They're up to 36 residential aged care facilities now. So it's really, really sort of scaling up and implementing that quite widely. So the work that we're doing with them is actually embedding an evaluation or an implementation evaluation once these services have been implemented for about 6 months. And so we look forward to working really closely with the teams that have been involved in the implementation to look at the outcomes and learnings from this. The next project is sticking with the theme of older Australians, is around enhancing health monitoring for rural and remote elderly Australians. And so this project is led by Dr. Stephanie Baker from James Cook University, and it's really about harnessing the power of wearable technology to monitor health parameters. And so the team here have been working on AI algorithms for the measurement of things like vital signs, stress, fatigue, physical activity, and incorporating or teaching this wearable technology. It's a watch, as you can see there. I'm told it's one of the smartest watches on the market at the moment. Around monitoring of elderly patients in a non-invasive way. And certainly having this real-time monitoring, is really crucial for things like early intervention and improving health outcomes. And so they've actually in the process of developing a database that integrates this physiological data, which is really not available presently. So that's a really interesting space. The third project I'd like to share is about an engaging digital front door for LGBTQ+ individuals in regional Queensland. You can take a look at the website here. It's called Rainbow Health Finder. And this project is led by Dr. Cara Burns from ATech AI. This was actually a project that was co-designed with community, and they actually ran their focus groups and co-design sessions out in Townsville and piloted the application there as well. And last time I looked at it, I've taken some screenshots. They've actually developed and designed these avatars, avatar characters that actually help to navigate people through the system to identify healthcare services that are LGBTQI plus friendly. And so this program, whilst it was developed and implemented in regional Australia, has lots of much wider application as well. So that's been a really different and interesting program. The last one I want to share with you, a little bit different, is a osteoarthritis triaging tool. And so, as many of you may know, the orthopedic outpatient system is completely overflowing, like lots of other systems. And you know, coupled with the fact that, you know, if you're living in rural or remote locations, this can be really challenging to even see a surgeon or get a clinical appointment, if you will. And so this tool actually looks at the X-rays to classify images for the presence of osteoarthritis, and it essentially triages the outcome from this sort of learning module and grades the analytics. And so that way, you know that, you know, perhaps it's more of a preventative issue rather than having to see a surgeon or, you know, preventative care. And so last time when we spoke with this, so this project is led by Maxine Rickman and the team from Foulkes Healthcare. They were actually rolling out a feasibility or validation phase study out at Alice Springs, where they were comparing Alice Springs Hospital, where they were comparing AI model outputs with manual assessments. So we're looking forward to seeing the outcomes of those. I guess where I'm going to finish up today is, it would be remiss of me as someone who is an implementation scientist to not finish on implementation. It's obviously a really key part of my role with NARDHC. But I'm going to leave you today with, you know, just to think about, if you have projects or you're planning, if you're planning digital health programs or projects, to really think about implementation. And, you know, a lot of people think implementation is just the application or adoption into service, but, you know, there are really early points on that you can start thinking about this process. So from your evidence-based practice, you know, needs identifying barriers and facilitators, needs assessments and testing, really help to ensure the effectiveness of real-world settings, sustainability, and of course, you know, it's all about the scale up and applicability to different care settings. So whether that be rural or remote care settings or different types of services and organisations. So I really encourage people to start thinking about how they can consider implementation early on in their projects, and certainly certainly reach out to us. This is something that's obviously we're really passionate about. You know, to have a conversation and to learn more about. We'd love to hear from you. I'm going to pass on now to my colleague Daniel to talk about interoperability and all things integrated. So over to you, Daniel.
Thanks, Michelle. We probably won't get to all things today, but we'll certainly make a start. So what I'd like to do is to address 4 different areas. First of all, just looking at health information sharing in general, and what is the particular challenge, problem, whatever you choose to call it. I call it a problem of fragmentation of data in rural and remote setting, particularly. Of course, it applies more widely than rural and remote, but our focus today is particularly on rural and remote, and the problem is most notable in that context. Secondly, I'd like to look at a positive initiative that's taking place at the moment with regard to information sharing. It's still in fairly early stages, but we'll be talking about the Sparked initiative. And then I'd like to briefly touch on what we've already mentioned today, health information exchange as a platform for enabling widespread data sharing. There's been quite a lot of discussion, if you're involved and on the circuit from the Australian Digital Health Agency and various other forums, people talking about HIE, but I'd like to make it as practical as I can. I've got experience working in that space internationally, and I believe it's quite something that would be quite very significant for Northern Australia and North Queensland. And finally, subject to time available, I'd like to then bring together those threads and look at a particular use case around acute rheumatic fever, rheumatic heart disease. What could be done about it? How can interoperability make a difference? So I'd like to start, next slide, please. I'd like to start by telling a story, because I think we need to keep the focus on the patient and then secondarily on the clinicians working with the patient. So here's Joe. Joe lives in the Cape in a remote community. He generally goes to an Indigenous health provider for his regular primary healthcare needs. He has chronic disease, so he has multiple others involved. So the Indigenous health provider has a fly in, fly out GP who's only there 1 or 2 days a week. So if not available, if he has a concern, he goes to the state primary health clinic, which is just next door anyway, but has a completely different medical record. As well as that, he might be going to Weipa Hospital for minor interventions that need to take place, and to Cairns Base or Townsville or somewhere with a larger scale hospital for more serious interventions. He's also got interactions with various allied health professionals who engage with them and disability services because of the impact of his chronic disease. And of course, then he travels from time to time and he might visit another GP somewhere else in North Queensland. Then there's all kinds of other areas of data that are collected. Now, each of these have their own individual medical record systems, and there's very little connectivity between these. I don't mean physical connectivity about the internet, although that used to be a huge problem up here. It's less of a problem now with Starlink and some of the satellite services, but the actual ability of these systems to share information, even within a given organisation like one HHS, can be quite significant. So there was a recent case study that we looked at for Torres and Cape, where there was a particular team that was involved, and they had multiple 20-something different interactions of sharing data with 6 or 7 different systems that they had. That's not unusual even within one organisation, but then going across organisations, we have this problem because none of these providers have access to the full set of data. There could be 4 or 5 different people at least prescribing medications without visibility of what medications are already there. Joe might forget to bring his bag of meds along with him when he comes to see the GP, and he's not going to remember the names of what they are. And so we have this problem of decisions having to be made by clinicians with insufficient information. And there's all the risks that are around that, both for the clinician and especially for the patient themselves. So I think you're probably all pretty aware of this situation already, but I think it's important to spell it out. The problem is fragmentation and isolation of the information and partial information availability. So if we go to the next slide, here's a picture of what we would like to get to. The goal is not that everybody has the same system, because that's simply not practical. Each of these providers have their own specific needs. They have experience working within their own existing medical record system, and there's not a need to try and push everybody to the same one system, and the tendencies and approaches to do that have never been successful in the past. So if we could have all this information shared around this whole circle of care, then that's the ideal. So keep that in mind, and we'll talk about steps along the way towards that. So just to next slide, please, sorry. Just to pull out some specifics around that. The goal would be to have the health information shared across health providers, to have that across the whole patient journey. So you've got primary, acute, tertiary, allied disability services all being able to share appropriately with one another. There's then the ability to create a consolidated patient record, which then enables continuity of care across different providers. It doesn't require a monolithic single system. So we're not all trying to say we all have the same piece of software that doesn't do anything perfectly for anyone. And the focus is on sharing data using a common standard language rather than trying to consolidate everything in one place owned by one organization. So this then also addresses some of the concerns around data custodianship. So that's a set of goals, ambitious set of goals. And of course, we're not going to get there overnight, but let's look at some steps in the process. So next slide, please. Actually, no, I think the next slide is looking at, okay, so this is looking at, we have quite a few different systems for sharing partial information in rural and remote contexts in Northern Australia. And in a way, they have become part of the problem because none of these systems actually do a complete job of sharing information. And some of them have been more successful than others. Technologies like the viewer that is used in Queensland Health is great, except that it only has QH data. And it's not accessible to allied health workers and to many others who are involved in working in the space. But almost all of them are based on proprietary underlying technology, and almost all of them have only partial information scope. So there are, I could probably list about 10 or 12 different initiatives, and most providers will have some degree of access to almost all of those. And that in itself creates an overhead of having to upload the same kind of information to My Health Record, to the viewer, to all of these different areas that are part of the compliance of delivering health, and yet they don't provide the value in return of shared data. So I don't want to focus too much on the negative, but that is the reality of what we have at the moment. The next slide, please. So one significant initiative that I think has a lot of potential for the future in Australia is the Sparked initiative. It's an initiative that is led by CSIRO, but is supported financially and governmentally by DOHAC and by the Australian Digital Health Agency. It has involvement from quite a few, all of the main vendors, so all of the main EMR vendors, both globally, like Epic and Cerner, or Oracle Health as they are now, and best practice, Telstra Health that has Communicare and Medical Director. So there's a widespread group of people involved in establishing a set of standards for interoperability for Australia. So these are based on FHIR, which some of you may have heard of, Fast Healthcare Interoperability Resources, like NARDHC. Very few people use the full term, and we use the acronym instead. But this is the dominant global standard for health interoperability, supported not universally, but very close to that internationally. And the Sparked initiative is about defining Australian-specific standards within that context. So we're not changing the language, but we're refining it so that we support all of the Australian specific things like Medicare provider IDs and IHIs and all of the other the values that are significant in Australia, Indigenous status, and so on and so forth. So there are three main work groups involved. There's a clinical work group, which I would encourage you all to consider involvement in, called AUCDI. They're very open to anyone coming along. You don't have to be highly technical. You don't have to be experienced across the whole board, but they value input from a wide range. And then there are two more technical working groups, one called AU Core, which is focused on the main resources. How do you define a patient? How do you define a condition, an allergy, and so on and so forth, technically speaking. And then a more specific one on pathology and imaging. So as a part of NARDHC, I'm involved in particularly the last two of those. I've been also to some of the clinical meetings as well, but I don't fly the flag as a clinician. I fly the flag as a technology guy who understands a little bit about clinical background. But where I do have input in this area is in the rural and remote context, because often the perspectives are dominantly coming from Melbourne, Sydney, Brisbane, and it's great to say what won't work in a remote area. So encourage your involvement in that, and you to look into that should you be interested. So changing tracks a little bit, I wanted to look briefly at a platform for sharing of information. So what is a health information exchange? Again, this is a term that you may have heard bandied around recently. It's particularly in the last 12 months or so, there's been various people talking about it. There's been a large multi-million contract awarded to someone who, anyway, I won't go there. But the reality is it's still a long way from actually changing the face of things in the short term for rural and remote. So my proposals are based on a health information exchange to work in the context of rural and remote Northern Australia. So what is it? Health information exchange is something that enables participants to keep working within their existing software, but collates the information from those different areas, consolidates it together to provide a consolidated patient view that is then available to the participants. And along with that, there's the mediation of who should access what. This isn't a once you're in, you get to see everything, but it's based on your relationship with the patient, the roles of different people. And this is in line with all international best practice around this area. And it's secure, and it links information across the whole sector. So from primary, acute, tertiary, allied health, disability. So that's the goal. Next slide, please. So it's based on standards. So one of them is the FHIR standard that I was referring to, and the Spark AU Core specification that's coming out of that. But as well as that, there are standards that some of you may be familiar with for different value sets of codes that are used for describing conditions, procedures, medications, and so on and so forth. So we use the appropriate standards for North Queensland, some of which are national, some of them are regional. The intent will be to use the IHI as the unique patient identifier where that's available, realising that it isn't always going to be available, and to align with the healthcare interoperability plan. Next slide, please. So from a technology point of view, and I know some of you will not be interested in this, but some of you may be interested. This is what a health information exchange looks like from an architectural point of view. So we've got on the left-hand side the various sources of information. So hospital and health services, primary health, and so on, coming into a place where the data is made into a consistent format. And then the bottom two layers, the data layer and the services layer, are really the nuts and bolts of what a health information exchange is all about. It's about aligning patient information together. So you have this thing called an EMPI for managing different names for the same patient, and variability in dates of birth, which, as you probably are mostly aware, is something that we have to deal with, and storing the core clinical information. And then at the top two layers are really about the potential to add disease-specific modules, and I'll be talking a little bit about acute rheumatic fever and rheumatic heart disease in just a couple of moments. So I won't labour this, but for those of you who are interested, that's what the software architecture looks like. Next slide, please. So let's talk briefly about acute rheumatic fever and rheumatic heart disease. Now, obviously, there's more to it than just this, but one of the big problems with ARF, RHD is managing the frequent ongoing medication requirements, so particularly the bicillin injections that are meant to take place on a 4-weekly basis for 10 plus years. But also things like echocardiograms and such like. So I've listed here 5 main workflows, or 5 main features, if you like, that have to take place: the registration of the patient, creating a patient care medication plan, recording individual medication administrations, and recording and tracking the echocardiograms, so on. And then, of course, at any stage in the process, the need to actually find out when a patient comes to your clinic from somewhere where you haven't seen them before, but you believe they may have ARF or RHD history, to be able to look it up and to find out how long is it since they last had their jab, and how many days at risk have they had over the last year or so. So flick to the next slide. So just a visual of some of those workflows, how they all work together in terms of a time flow left to right, with the medications shown in there. Next slide. So the intent for this is that there be a proof of concept of a new style of register. So as you may be aware, there are registers. ARF is a notifiable disease, and RHD is becoming a notifiable disease in most states and jurisdictions. But in many cases, the states manage their own bespoke registers, which are more oriented around the need to track communicable diseases than around supporting the management of a patient condition. And so this is trying to move from that simply just having a spreadsheet of all the different cases and analysing them by location, to actually being able to provide notifications to update clinicians who are busy with, hey, maybe you need to send a health worker out to see so-and-so because they're a week overdue, or they're coming up for needing their next medication. So there's lots of ideas, particularly around that, but here are some of the technology features of that, which I won't labour, but it's there if you're interested. And then I think I've got one more slide, I think. So then this is the actual architecture. If you look at this alongside of the previous architecture slide, you'll see a lot of similarity, because basically this is just a scaled down health information exchange for a single purpose. I think I've done my session on this. So I think I hand back to you now, Michelle, is that right?
Either of us is fine.
Okay, sorry, Sarah.
I'm happy to go. Yeah, either of us is fine. I was going to do the questions. So I mean, I hope you can see. So we have a really big vision. Thank you for those 2 great presentations. Where you know that Michelle and Daniel have been doing an absolutely fantastic job of this. We have a sort of, you know, lifetime vision for how things could look for North Queensland in terms of systems talking to each other. But clearly there's an enormous body of work to do about governance arrangements, about social contracts with communities and individuals, about data sharing, and then of course about implementing the technological architecture in the form of a health information exchange. What we're trying to do is keep that overarching framework in place as a long-term vision, but operationalise use cases bit by bit with health sector buy-in. And we're looking for other ones of those. So this acute rheumatic fever, rheumatic heart disease register. The idea came from Torres and Cape HHS. We're working with the ACHO sector, which operate and other services, and you know, trying to get things up and going with that. We'd like to do the same with other potential use cases. There's an enormous amount of potential of doing this in terms of improving healthcare quality and safety, and health worker burden in terms of chasing up results and data and information about their patient, and the satisfaction and actually meeting the expectations of patients in areas who just assume that the health systems that they go and visit should be able to talk to each other automatically. So there's a lot to do. It all depends on strong partnerships and collaboration, but addressing the interoperability issues is really, really critical, and thinking about all the bits and the implementation and evaluation of them as we go in partnerships is also critical. So I think we'll stop there. Next slide. Oh yeah, that's okay. That's good. Thank you. The last slide was just a thank you to Danielle and Michelle, particularly, and with their contact details. So we'll send that around. They're both on JCU emails. And you can
also shoot us an email through our website as well. We have a contact page that we all access, so we're very easily contactable.
Yep. So I'd like to throw open for any questions or comments. Please feel free to put your camera on. You can put them in the chat if you're feeling really shy or are in your pajamas, but it's always nice to see some faces with a not too big group. No. Nothing at all. We've blinded them with possibilities. Not seeing anything in the chat at all. What do you think? Are we being pie in the sky? Great work. Who's RL? Hi, I can see you there. I'm just not a familiar face. I'm just wondering. Yeah, no, it is very interesting. It's a huge potential. It's one of the only places in the country, I think, that we've got the geography and partnerships that we could actually. It's conceivable to do this. We've got the combination of the skill sets required in the team to get it happening, and with the partnerships, the collaborations with the health centre, the health services through TARC and Better Health NQ, and lots of potential to take it forward. But yeah, you know, little bit by little bit, we've got to keep working on these restrictions. Is it all Queensland specific? So it's a Northern Australian partnership. RL, it's up until now, it's been a North Queensland specific activity largely. That's because our NT and Northern Western Australian partners wanted us to sort of try and put some things in place, and then they're very keen to sort of follow and see which bits are applicable in their context. But you would have seen from Michelle's presentation that some of the piloting and testing of different things has been in different states. So for example, we had Alice Springs for the osteoarthritis tool that was tested in Alice Springs Hospital, not so much down south, but I can imagine some of the techniques could be applicable down there.
Sarah, just quickly, I was in a conversation yesterday for discussion of the ARF RHD register for Western Australia. They're very interested in that as well.
Yep. Yeah, that's right. And they're probably the leading state in terms of systems for data sharing for research and service delivery. You know, I think that's probably a fair comment, but they're keen on this sort of thing as well.
Sarah, I'll come off mute.
Yeah, good on you.
Yeah. many questions. Well done to all of you. It's fantastic. I'm a ex-grad of JCU MPH. I see Ian's online. My name's Richard Munns. I'm RL. So I've actually emailed you a few times. So yeah, just doing a few projects down here, and so I was quite interested in what you've done, understanding that you have your unique stakeholder engagement up there. So I was just inquiring if anything's if anything can be replicated down here, or people I know in some commercial startups can work with you guys. That's what I was just trying to find out. I've sent you separate contacts as well.
Yeah, no, absolutely. Follow up with the team. There's a lot of potential transferability, I guess. Michelle, do you? Yeah,
absolutely. I think it's we're in a position now. If I can speak to Daniel and myself, we have the seed funded projects, and a bunch of other projects, all chipping away at their pieces. None of them are certainly finished by any means, but the energy that Daniel and myself are able to give now are much more focused projects that really align to NARDHC. So it really is a case by case basis. So we're really open to having a conversation, and seeing what you have, Richard, where the opportunities might lie, and the alignment. So if you shoot an email through to myself, or just the NARDHC, we can NARDHC email via the website. We can catch up.
Lovely.
Thank you.
Well done.
Just one more thing, Richard. So the work that I'm doing architecturally and development wise, it's all going into open source.
Yep.
So it's published. It's anything that someone else can pick up with. And one more comment I was at a recent sparked initiative in Darwin for rural and remote health, looking at engaging across that area in terms of interoperability. And one of the really interesting comments that came out of that, I thought was very telling, was one of the clinicians saying, if we get this working in rural and remote, we can then easily use this in an urban context, but it doesn't work the other way around.
Yeah.
So if we can solve these problems with all the challenges of remoteness and difficult connectivity and everything else, then it's going to work in other places as well. So I think there's a lot of potential spin-off value beyond just Northern Australia, but obviously that's our target market, if you like.
So Daniel, having said that, 2 questions in one, if I may. Sorry if anyone else wants to ask questions, quick, go for it.
No other hands up, so go for your life.
Have you done any quality surveys and responses in that respect, either with or without co-design with GPs and other stakeholders, or is there engagement with the PHNs beyond what you've shared on your site? Is it moving ahead with GP involvement?
Yeah, so in terms of my engagement, I'm talking very broadly at with local GPs, with Indigenous providers, with people from the various HHSs at a state level, and with the e-health guys from Southeast Corner. And so in terms of formalizing that, no, that hasn't been done. We're not at that stage yet. But in terms of gathering inputs, advice, trying to concretize particular proposal around the ARF, RHD, there's been quite a lot of input. And also to some degree, also with Nacho on a national level.
Yeah, and so the ideas come from the NARDHC roundtables, which have healthcare providers, including GPs, involved in them. And I'm a GP who's spent most of my career at the community controlled setting as well, in Archos, and so and have been sort of pretty involved in the team. So we're absolutely, I think that co-design moving forward as it plays out to make sure we've covered everything. But it's not been done. What's been done so far has not been done without clinical input. So, yeah.
Cheers. Well, congrats again to all of you.
Yeah. And Daniel's a rare person, a technical guy that speaks health from employment in past employment in Queensland Health, Apuna Pima, and PHN. And the PHN's been quite involved as a partner, both through TARC, but also independently, and quite an active partner. So the NQ-PHN actually contributes to Michelle's position, and the eHealth Research Centre of CSIRO contribute to Daniel's position. So they've got, you know, skin in the game as well. Yeah, yeah. Okay, anyone else? No, well, that's perfect timing. Thank you for the presentations, Michelle and Daniel, and all the organisation. Michelle is steering us all in the right direction, and thanks everyone for coming. And I hope it's an ongoing discussion. That Michelle and Daniel are really approachable. The website has all the links, and if anyone's interested, we can send around the slide deck. Just let TARC through Shannon through TARC know, and we'll send it around.
Thanks.
Thank you very much.
Thanks, everyone.
Thanks,
Okay.
everyone.
Thank you.
Bye.
Bye.